May I first request Dr. Vijay Viswanathan to start with his introduction on diabetes control.
It's an honor for a clinician like me to be in the midst of field epidemiologists like all of you. Thank you, Dr. Prabhdeep, for this invitation. I'll just take 3 minutes to talk about 3 very important aspects about which the panel discussion will definitely focus. And the first point is about the magnitude of the problem. As you can see in this slide from the International Diabetes Federation, this is the, I'm trying to use a pointer, but it's not coming onto the stage. Okay, so can you make the pointer work so that I can show it in both the screens? Yeah. So if you see India, it is going to see a nearly 84% increase in the prevalence of diabetes compared to, say, the United States, which is going to see only 35%. So diabetes is going to be a big issue in the low and middle income countries, India, China, Indonesia, Pakistan, and so on. And the mouse is still not working. It doesn't matter. You can see the map of the Southeast Asia, where diabetes is going to be a big problem compared to the developed nations. Now, it is estimated that India would have more people from diabetes. No, I actually wanted to show in both the slides, that's why I wanted to have this mouse working. It doesn't matter. Because if I show the pointer, it will be only here, and those people can't see it, so it doesn't matter. So if you see, India is going to have more people with diabetes than any other country in the world. Now, China is ahead of India, but if India doesn't do something about diabetes, we would have more diabetic people with diabetes than China. The problem about diabetes is not a single entity. It produces a lot of damage, as Professor Sankaranarayanan said. Cancer is not a single entity. It produces a lot of damage. Diabetes is a problem which produces a lot of damage to the organs. Every single organ in the body is affected. I don't think there's any organ which is not spared. Recently they said even psoriasis is associated with diabetes. So diabetes is a disorder which affects every part of the body. And mostly where I focus on, I think this is the major problem in India. People are losing their legs because of diabetes. And diabetes contributes to more amputations than even road traffic accidents or terrorist attacks and so on. In India, more people lose their legs due to diabetes rather than road traffic accidents or terrorist attacks. Now, we will be discussing this in the panel discussion. The main problem in India is Indians are called thin, fat Indians. Indians have less muscle mass, but they have terribly excess fat inside their organs. They have what is called the visceral fat, which you can see in this diagram. And the visceral fat leads to a state of inflammation, which you can see, and leads to all sorts of changes in the system with respect to the glucose metabolism, with respect to the cardiovascular disease, hypertension. So the visceral fat is really the culprit among we Indians, and we Indians are called thin, fat Indians. We are thin, muscle mass is less, we have sarcopenia, but we have too much of fat inside our abdomen, inside our liver, in the viscera, and so on. And that's because, if you see here, we Indians take too much of carbohydrates, about which we will be discussing in the panel discussion. This is true for any rural population or the urban population. You can see in this study, Chennai had the highest intake of carbohydrates, maybe from pongal and vadas and dosas and all that. So we need to definitely cut down on the carbohydrate. And last 1 minute, let me talk to you about what we need to do. because there's no point in saying there's so much of diabetes in the country without telling all of you what we need to do. What we need to do is what is called primary prevention of diabetes. If you want the numbers of diabetes to reduce and prevent a situation where we overtake China, we need to do what is called prevent the onset of clinical diabetes. We need to have some risk scoring. There are 2-3 risk scores in India, where you have obesity, central obesity, strong family history, sedentary lifestyle, and so on. There is a risk score, and then you do testing. And if your blood sugar, the blood sugars which start going up first is the postprandial blood sugar, not the fasting. So if you're going to look at the fasting blood sugar, you'll miss the bus. You have to do what is called glucose tolerance test, which reflects the increase in the postprandial blood sugar. And you can see that the complications of diabetes, with respect to the heart, which is called the macrovascular complications, start even before the postprandial blood sugar goes up. Even if your GTT, as you can see in the next slide, even if you do a glucose tolerance test and if you find your post-glucose values are less than 140, by the time the cardiovascular disease has already set in. Therefore, the preventive strategy in India is to do what is called glucose tolerance test in people who have a very high risk of getting diabetes. And that's a 75 grams glucose tolerance as advised by the World Health Organization. And if you have a value between 140 and 199, you're a pre-diabetic, you have impaired glucose tolerance. That's a stage when you institute all the preventive measures and prevent this individual from becoming a diabetic. Lastly, we have been doing a lot of studies in diabetes and tuberculosis. Now, we find that there's a huge connection. We're not talking about TB occurring in diabetes. That's an old story. We're talking about diabetes occurring in TB. So we found in this study, which we published some years ago, we found that nearly 25% of the TB patients in our tuberculosis units, Puliandop, and we did it in the urban, as well as we did it in the rural tuberculosis units in Kanchipuram and Tiruvallur. And we found that the prevalence of diabetes among the TB patients was very high. And this is a situation which was similar to what we saw a few years ago, the HIV-TB connection. Now we're talking about diabetes-TB connection. Diabetes produces more TB cases. It's more difficult to diagnose TB if you have diabetes. You have increased death, you have increased recurrent TB, and so on. Therefore, I think the time has come to focus on this double burden of non-communicable, communicable disease. Therefore, while talking about diabetes, we should also talk about the prevalence of non-communicable diseases like TB, which occurs in diabetes. So these are the 3 points which I wanted to focus, and I would like to thank Prabhdeep Kaur for this invitation. Thank you.
Thank you very much, Dr. Vijay Viswanathan, for very, very quick and comprehensive introduction. Now, I may request Dr. Jerard Selvam to share with us Tamil Nadu experience very briefly, sir, because we're going to have a lot of discussion around it.
So good afternoon, everybody. I've got very few slides, some 7-8 slides, because it's a long story. The Tamil Nadu government has really involved itself in the implementation of NCD intervention program over a decade now. So the slides are 10, at least I've restricted 10 to tell it as briefly and as succinctly as possible. So there's a string of milestones. We have a history of talking about NCD intervention as an important activity way back in 2005 to 7, and during 2007 to 10, it was piloted. This was all done under the aegis of the Tamil Nadu Health System Project, the World Bank Support Project. So there was a pilot done for hypertension in Virudhunagar and Sivaganga, and for cervical cancer in Theni, Thanjavur. Then we upscaled in a phased manner to all the districts during the year 2012 to 2013. Then the World Bank supported Tamil Nadu Health System Project came to a closure in the year 2015 September, and from then it came under the umbrella of NHM National Health Mission, and now we call it as the NPCDCS program. So this is how we did extend the program, upscale to all the 32 districts during the year 12. Initially 16 districts were covered in the year 2012, and the balance 16 districts in 2013. So I would like to place on record here what are some of the important things the state took forward this program, a very important program, a very important intervention for non-communicable diseases. So forming the state NCD cell and the district NCD cell, it was a concept even originally when we started off the program under the TNHSP. Second was the component to have NCD staff nurse, female NCD staff nurse in all the health facilities, at least one in a PHC and two in a government hospital. The third one, the central procurement, whatever you need for the program through the Tamil Nadu Medical Service Corporation. Training, that doesn't stop by itself, training and refresher training. Then how you simplify the protocols, how you make it as simple as possible for a PHC doctor to treat hypertension and diabetes, and also to screen for the cervical and breast cancer and then go further. So that was another important element in the health system strengthening. Then the dedicated statistical assistants were put those days. Our counterpart was the National Institute of Epidemiology, who did the concurrent evaluation for the program. They did for the pilot, they did for the upscaling. They are also shortly going to be again brought on board to concurrently evaluate us and guide us. So there was an element of statistical assistant for one for every district. Then we had a district program management unit, which we now call as a district NCD cell, and there was a coordinator. And there were certain IEC strategies for which we had spent a lot of funds from the World Bank funds to really take the messages to the community. The other important lesson we learned as we grew with the program during those years, one of the important things we experimented and also learned was what now everybody else is talking about it so seriously in the country about multisectoral. We had these elements introduced into the program way back. One was involving the education department to have some school-based awareness creation activities covering about 17,000 government schools. Then involving the rural development department by utilizing the services of the self-help group women network in the community. And then we tried on a very selective basis certain activities in some selected workplaces, could be industries and factories, which we did it through the labor department. Then the ESI was also part of the clinical intervention, that means the clinic-based NCD intervention. The municipal bodies, we had selected about 100 municipal bodies and 10 corporations and about 100 municipal health facilities, which also were part of the clinical implementation of the NCD program. So the program had certain concept towards this point, the multisectoral involvement. So I will touch upon the important challenges. HR and capacity building issue was a challenge because to start with, to go for a huge number of staff nurses, recruiting them, and then training them, refresher training or retraining, that was always a challenge. And then it was a new protocol, new program, a new burden for the people who were already doing the regular mundane work. So it involved certain administrative approach to make them comply with the protocols and do the program. And then we also had the CME for the specialist now and then to keep them in pace with the program needs. And then attrition of staff is a perennial problem for anybody in the country. So, and then shortage of gynecologists is also common for many states. We faced all that. Structural issues, to start off, we had issues like giving a place with privacy for screening women. So the structural issues were there, and privacy of the women you have to ensure. Data issues, this was a manual data. Then we started working on the online screens, and then there were struggles to transfer the manual data into the online system. All these things was a learning experience for us, and they were the data issues which were a challenge, huge challenge, and they continue to be a challenge even now with a lot of newer things coming, gadgets and apps and other things which are coming these days. You all know like what we are talking these days about apps. Now coming to the procedural protocol issue, the deviation from the protocol, and then the need for revision of protocol after you implement, when you think that you need to do some mid-course corrections in the protocol, and resistance of the doctors or other people to do the screening, the resistance to comply with the treatment protocol for hypertension or the treatment protocol for diabetes, social issues initially, women not coming forward for the cervical and breast cancer screening, budget issues. IEC is worthwhile, but it demands a lot of funds to be pumped into it. So that was also an area like where like IEC, to sustain IEC is not a joke. So the salary part, all the logistic part, reagents, everything. And then what did we do? How did we sustain the program after the World Bank program came to an end? When we migrated on NPCDCS, what were the struggles we faced? We know that too very well. And the large-scale supply, it involved huge supply of drugs and reagents, forms, cards and everything. And then initially to get all this into the pipeline, to bring everything into place and then time it along with implementation, you need all those things. And the integration, how do you integrate the levels of healthcare, primary to secondary to tertiary? If you take cancer, it doesn't stop with screening, it doesn't stop with primary. You need to link with the secondary and tertiary. So, and also like for hypertension, diabetes, when it gets into complications, how do you link the treatment services at the district headquarters level or with the tertiary care institution, the medical colleges? Follow-up issues, follow-up and treatment of hypertension, diabetes patients, because it's a chronic disease, leading lifelong treatment. How do we ensure that? What are the challenges? How regular are patients? How they default? And what happens to their drug collection mechanism? How they report later with uncontrolled diabetes or uncontrolled hypertension? What happens to the VA and CB positive women who are positive in the screening for cervical and breast cancer? How do you take them to the last step of having them diagnosed, confirmed and put on treatment? And the break in the referral linkage at any point, be it investigation to confirm or be it in the treatment, that a break in referral linkage is an issue. So we'll highlight few points here how we overcame some of the issues. So storytelling, it's more of a storytelling what I'm doing. We had staff nurses who are on the regular side. In between there was a problem in getting them on regular, so there was an issue because of the court case. So we had to outsource staff nurses. So that was done as an innovation to overcome that block. Second one is like to get all the space with privacy in all the institutions, to make the districts to comply with that was done by the administrative approach. Periodical training, and then utilizing the Chief Minister's insurance scheme, both for initially it was for treatment, but then we also ensured diagnostic and treatment services got incorporated in the CMCHI's program, Chief Minister's Insurance Program. IEC activities utilizing the self-help group women, that was an experience. The data capture and the data compilation, reporting, so many things, online system with the IT team. We had to work with the IT team to develop the fresh HMIS Ncd online screens. There were a lot of teamwork involved in that. I will not say it was totally successful, but I can say that we learned a lot out of it. And then there were always meetings, inspections, on-site supervision, or you call it supportive supervision, the video conferencing, all these were there. We developed a lot of IEC materials and the display boards. And then we had to make an exit plan to come out of the World Bank project and then to come under the National Health Mission. So we had to make an exit plan and then to see like how we were going to seamlessly come out of this and then get involved in the new setup. This is the current setup, how we are, the NPCDCS, under the Health and Family Welfare Department, you got the National Health Mission, got the 3 directorates, each directorate is supposed to have a nodal officer, you got a state unit, state NCD cell in the NHM, and then you also have a district NCD cell with the district program coordinator and the support staff. So there are a lot of things, the ramifications which have happened in the program now. A lot of good things also we learned out of the NPCDCS and the other programs related to the NCD in the NHM. You got a care for the elderly program, you got the mental health program, you got tobacco control program, you got program for blindness, palliative care program, oral health program, daycare, chemotherapy centers, dialysis units, cardiac care units, and then you got also the rheumatic heart disease prevention program through the RBSK, integration with RNTCP and Ayush, diabetes and your TB coordination, and then the population-based, house-to-house going and screening. What we were doing earlier was the facility-based. It still continues. It doesn't stop. It will continue. But the other important arm or the element which is added now is the house-to-house screening individuals, for which we have again used now the self-help group women. And then that is another very important element we are discovering to make or to access people. Access issue is always an issue, because if you got a government facility, certain percentage proportion will come always. Now what happens to the others who don't come to the government health facility? So population-based NCD screening is a real it's a real contributor that way. So all these components under the NHM, you will see that they complement the NCD activities, the control activities. So that is one thing. So I've tried to say in short, like how we started off, how we evolved, I don't know, in a short time, and I hope it was useful. Thank you.
Thank you, sir, for summarizing a very long story. I'm sure it was very tough for you. Now I request Ms. Prachi to share with us their experience on engagement of civil society for control of non-communicable diseases. We really wanted to keep our perspective very broad in this discussion, because we always keep looking at NCDs more as a medical problem, but it's a broader societal issue, and I hope Ms. Prachi can make that case, so that all the people in this group who are working in the program should not only look at NCD from disease perspective, but from a societal perspective.
Thank you, Dr. Kaur. And we are actually very honored that we have this platform to share the civil society perspective also with public health experts as well as epidemiologists. To start off my talk, I would really say that this is very apt, and this day is very apt for discussing multisectoral and multi-stakeholder approaches to NCD prevention and control, because today marks the World Obesity Day. And obesity is not only an outcome of various risk factors like physical inactivity, unhealthy diets, alcohol use, but in itself is a risk factor to various NCDs, including cardiovascular diseases and cancers. So, which therefore, obesity in itself really leads us to this discussion of need for multisectoral, multi-stakeholder approaches. HRIDAY is the Secretariat of the Healthy India Alliance, which is an alliance of India NCD, which is supported by the Global NCD Alliance and is the India NCD Alliance, and is an alliance of approximately 13 civil society organizations and 3 associate members, and RTI International is one of our member organization. And the alliance is really committed to bringing on board both health and non-health sector civil society organizations to advance the discussions around NCD prevention and control. So I'll briefly just take you through what the alliance is, and then we are, of course, open for discussion. Broadly, to just give you an understanding of what the role of civil society and alliances really is, it ranges from advocacy both in terms of working and supporting the government programs and getting those helping hands, extra helping hands to the programs that are there already, as well as working with various stakeholders at the grassroots level and reaching out to other civil society organizations as well as individuals, and advocating for health promoting practices and behaviors. Access to services, facilitating access to various services. Awareness generation is, of course, a very, lays the foundation of the work that civil society does, and accountability in terms of ensuring that the work that is being done reaches out to each and every person in the country. Just to give you a background again about the Healthy India Alliance, with that vision to catalyze multisectoral and multi-stakeholder action at both state and national levels, the alliance was set up in 2015 and is supported by the Global NCD Alliance, and is now expanding its membership to reach out to various states in the country. And right now we are in all the 4 regions of the country, the alliance has its representatives. So therefore we are working in the major 4 regions of the country. Some of the activities that the Alliance really undertakes is working with, just to skip one slide, so the core of the multi-sectoral and multi-stakeholder engagement that the Alliance is doing lies with working with various stakeholders, and that includes a list of people who the Alliance is working with. And of course, the work really spans from prevention to palliation, and that's the window where we see a lot of opportunities, and we work with young people. So there are a lot of campaigns and activities that are ongoing on the ground, and a campaign called the Enough campaign, which is around saying enough to NCDs and enough to unhealthy living habits, is something that is being practiced on ground with young people to promote prevention of NCDs. One of the key stakeholders that we very closely work with are people living with NCDs. This includes patients as well as their care providers, and their immense role in not only being champions and coming out and sharing their stories and creating a public narrative around NCDs in terms of calling for policies that are inclusive, programs that can include and utilize their efficiency and capacity as workforce, their role really pans out to being support systems to other people who are living with NCDs and are recently diagnosed. And there's a support system and a culture of health that they can help in building. So towards this, the Alliance has developed an India advocacy agenda of people living with NCDs, which is an outcome of approximately 200 people with lived experiences who came together, and they put down this advocacy agenda that pins out certain asks, certain opportunities, certain gaps that they think will help their condition be better survived. So this advocacy agenda is something that guides the action of the Alliance. We very closely work with health professionals and pediatricians and schools, of course, because there is where unhealthy behaviors really set in. And development sector is a partner that we see when we are talking about multisectoral approaches, and we do have a national multisectoral action plan of the government to prevent and control NCDs. So under that multisectoral action plan, although there is proposed that 32 government ministries will come together and work towards, within their ministries will try and identify opportunities where NCDs can be counted for. It is also important that civil society within their space also ensure that multi-sectoral engagement is happening in development sector, and so to say in the whole discussions around SDGs, Sustainable Development Goals, the development sector partners are on board and working towards health goals. Just my last slide. So there, just to see how civil society can strengthen and help implementation of the programs and policies, there are discussions around providing a set of guidelines to civil society as to how can they be engaged under the National NCD response, both National Multisectoral Action Plan as well as NPCDCS. How can those guidelines really be put in so that that engagement can be operationalized even at the state level? So those discussions are underway between the Healthy India Alliance and MOHFW. And if those guidelines are in place, then it's a guiding framework for civil society to act upon. Thank you.
Thank you very much, Prachi. I thank all the panelists for being very crisp and focused. So I think we can begin our discussion. It's a very broad area we have to cover in the next few minutes. So I would request all of you to give very focused messages, because I think we have an audience who are program managers and who actually are involved in designing and running these programs in their own states or districts. So I think let's begin with the whole issue around health system, and then maybe we can move on to civil society just to keep a sequence. And within the broad domain of health system, there are two ways we can look at it. One is prioritizing diseases, and second is prioritizing health system investments. So in terms of prioritizing diseases, the government of India has already prioritized 5 diseases: diabetes, hypertension, and 3 cancers, which is oral, breast cancer, and cancer cervix. So just to set the discussion, we can first work around. So do you feel, Dr. Shankar, that focus on these 3 cancers, is it evidence-based? Do you think it's feasible on the ground? Or what do you think are for these 3 cancers, what are the scalable strategies which the governments can implement?
In disease control, it is always better to be focused. But on the other hand, in the case of cancer, whatever investment we make has to be of benefit for the entire spectrum of disease. This is very important. For instance, the investments that you make in histopathology, immunohistochemistry, radiotherapy services, diagnostic imaging, tumor markers, will help a variety of cancers. So just focusing on, okay, these are important cancers, so I will focus on that. I think that can take away the attention from very important other issues. For example, childhood cancer. It took several years for us to convince WHO to say the value in investing in management of childhood cancers, because that is the #1 cause of mortality in children abroad, and this will happen so very, very soon in developing countries. So there you need to focus on centralized management systems. Hematolymphoid neoplasms, for example, non-Hodgkin's lymphoma, you will benefit in identifying the low-risk disease, where we will not intervene at all. You save a lot of healthcare dollars. And at the same time, you identify aggressive disease and you manage aggressively. So I would say in cancer, you make investments in such a way that will be useful for the entire spectrum as we go on building up the health system.
But could you just touch upon, for the primary healthcare system, since the government has prioritized these 3 cancers, what do you think are the scalable strategies for each one of them?
See, in the case of cervix cancer, one of the important scalable strategy is HPV vaccination. And Prabhdeep, you have been very key in seeing through the program in Sikkim and Punjab, as well as now, encouraging Himachal Pradesh to invest in HPV vaccine. It is scalable and safe and scalable. And the second thing is, in the case of screening, Dr. Jerard has already shown what Tamil Nadu has done. Okay, this is a via media policy via the visual inspection with acetic acid is a via media. Unless you reach a certain place, you build up infrastructure for diagnosis, treatment of precancerous lesions and things like that. Investing in HPV testing, a single HPV testing, focusing on 35 to 39 or 30 to 39-year-old women is a scalable strategy. In the case of breast cancer, as I already said, create considerable breast awareness. Talking about the disease and making the stigmas go and encouraging people to autopalpate and encouraging people to seek services for benign diseases and things like that. And build up the health system capacity for triple diagnosis, I've already shown. And then you have, once a disease is suspected or detected, the possibility to do basic surgery, which is simple mastectomy at the moment, because breast conservation is an advanced technology, and we do not have the capacity in many places to see the cosmetic results of breast conservation. And then the basic hormone therapy with essentially tamoxifen and basic chemotherapy. In the case of oral cancer, it's an investment for head and neck cancer. Because head and neck cancer, India is the capital of the world. Just like Dr. Viswanathan said, diabetes, India is the capital of the world. For head and neck cancer, we are the capital of the world. We have so much of head and neck cancers, which are a very important cause of morbidity and mortality in the case of cancer. So our focus on controlling alcohol, which we have miserably failed. For example, governments are monopoly in selling alcohol and promoting alcohol drinking, which is an unfortunate scenario in this country. And then tobacco control, particularly chewing tobacco and arecanut and all those, these are scalable. Then physical activity, as we already agreed, it's a multisectoral investment. Cancer prevention lies mostly out of health services. It is essentially developing good walkways in cities. In Chennai, I wouldn't walk. Previously, I used to walk between my in-laws' place and Cancer Institute. Now I will not dare to walk because there is no footpath. And recreational grounds are disappearing. So those type of investments to improve physical activity where you make people walk to work and to recreate and to do their day-to-day purchasing and things like that, people carrying on bags, just like what our Dutch compatriots do or the Nordic people do. I think these are scalable strategies.
Thank you, sir. Just moving on to Dr. Jerard. Sir, you heard that sir has just outlined the scalable strategies. So you have been actually working in this program, and you outlined several challenges. So we do have other people here who may be thinking of introducing these strategies or at varying levels of evolution in terms of how the NCD program is developing in various states. Do you have key messages for them? What do you think they could do to make sure that these cancer strategies can be effectively implemented and integrated in the health system?
Yeah. So if you ask me the wisdom behind NCD control, I would place a lot of importance on how governments conceptualize NCD. In other words, as long as we think of NCD as a health department activity, we can never ever control non-communicable disease in the community. It involves, actually, if you talk about lifestyle, how people live, the lifestyle practices, it starts from the womb and then to the point when somebody dies. So all along, the lifestyle practices are a real challenge. So the concept of NCD, we have to shift our mind frame from just not limited to the health department, but it is definitely multisectoral. And there are certain key departments which have to come together, they have to come forward. The other important message I would say is identification of the risk factors and addressing them. So it is not going to be a theoretical answer I'm giving. We have certain national programs which we are implementing. If you take the school health program, the RBSK, or the adolescent-friendly health clinics and the adolescent RKSK, the programs, if you look at all these things, we should look for the risk factors, especially the risk factors related to the obesity and to the tobacco and alcohol. These three are very important, and physical activity. Now, the question is, we often use this buzzword lifestyle change. Now, lifestyle change has to be understood in the context of what is current pattern of life is offering to us. We have crossed certain decades now, 2-3 decades now. From the earlier time when we had certain space to walk, certain space where children went and played around, made fun, they had their learning from their own peers, all that has vanished into under the cover of urbanization, it has all vanished. So with a limited space to move about, with very limited space, which is again getting further limited due to these gadgets and other things, especially the children, the way the social media has come into our life, each of our lives. We have to really think that lifestyle change, already it is set for all of us. Certain life practices have come into our life and it is already set. And from there, what change we are going to make is not an easy task. Be it for us, we adults, be it for the kids which is going to preschool or to the LKG, be it for the primary children or the adolescent or the adults, any point of life, the overall lifestyle, we are in soup already. So the lifestyle practices, to bring the change in the lifestyle practices needs lot of attention and to the risk factors. So these are the things I thought I should.
Thank you, sir. Thank you very much. Just giving you context that, you know, we have diabetes and hypertension as the two commonest non-communicable diseases. And literally, it's such a common disease that every other person you meet have either hypertension or diabetes, especially above the age of 50 years. So, Dr. Vijay, considering the magnitude of this problem, it is extremely difficult for governments to develop, implement, and scale interventions which are sustainable over long term, both in terms of infrastructure required, drug required, ensuring that people come back for follow-up and all of that. So especially when we look at diabetes, we have a challenge. There are multiple drugs in the market. There is all kinds of prescriptions. And just for health system to adapt itself to so much of complexity just in one disease, when the health system is trying to deal with multiple disease. So if you have to focus on, let's say, key interventions, which can be done in the primary healthcare system, diagnosis, treatment, follow-up, could you give some key messages which they should consider while designing the programs?
I'll be very brief because we're already lunchtime and we need to hear the audience. I think there are 3 sets of diabetics in the population. One set of people are not yet diagnosed. They have diabetes, not yet diagnosed, and they'll develop complications and they'll come with kidney failure or with amputation. So we need to ask the public health workers to ask people for symptoms. It's very obvious, and look for risk factors in them and ask them to do a simple blood sugar or a urine sugar and detect diabetes. So 1, detect undiagnosed diabetes in the community. 2, people who already have diabetes are not following their treatment properly. So motivate them to follow a lifestyle modification, take their drugs properly. The government is giving drugs, but they're not taking it. They're not going and getting their drugs from the hospital. So motivate them to take the drugs properly and test their urine sugar. They can't afford blood sugar. They can't afford glucometers. So go and test their blood sugar. And the third thing is the primary prevention. Try to prevent diabetes in the community by talking to the children, son and daughters of people who are already diabetics, and try to prevent diabetes by motivating them to do exercise. So I think what is scalable, what is achievable in the public health sector is, one, detect the undetected cases in the community. Two, teach the patients who are already having diabetes to follow a good lifestyle monitoring and so on, follow the diet and so on. Third is primary prevention. So it's simple.
Yeah. But just could you add on, there are many drugs in the market, and we need simple protocols so that physicians or clinicians who work in the primary healthcare can easily follow. So can you tell us if there are certain key drugs which the governments could potentially consider in their protocols?
So I think the government right now is giving sulfonylureas and metformin, which are wonderful drugs. Whatever you talk about the newer drugs and insulin, these two drugs have stayed in the market for the last 3 decades, and we did not have these newer drugs 30 years ago.
Right.
It's only now it's there and people are talking about it. Maybe the pharmaceutical companies are driving it, pushing it a bit too hard. So I think the metformin and the sulfonylureas, glibenclamide is not used, but glycoside and glimepiride are excellent drugs for controlling diabetes.
Yes.
And the government can afford it. And they're giving it from the generic Prime Minister's scheme and so on. They're giving it so cheap. So the wonderful job being done by the government in giving drugs which are generic sulfonylureas and metformin. You don't have to use the gliptins like sitagliptin and so on, which is expensive. It's 40 rupees per tablet. You don't need them.
Yeah. Thank you. I think that's a very important message we have got from Dr. Vijay. And also it came in Dr. Jerard's presentation that it's about having simple protocols and basic drugs available. It's more an issue of ensuring that drugs are available in all health facilities and they're accessible and they are free so that people can take their supplies at least for 30 days rather than having multiple drugs but neither of the drugs being in the adequate supply. So just coming to the issue of drug access, I know it's one of the core areas that civil society is globally working on for cancers as well as for diabetes. Would you like to comment?
I think when we started as an alliance also, the whole concept of palliative care really was something, and I'm just saying in terms of pain relief going on those lines also. Palliative care in itself was something that was not a part of the discussions, or it was considered end-of-life care. And as an alliance, as we grow, as we connect to people who have lived experiences, we also understand that it is not just end-of-life care, but we also need to talk about palliative care as a strategy to manage and better manage, so to say. We are already managing NCDs, but to better manage NCDs. And it really starts from the day a person is detected with an NCD. So that support really, and we understand that there is a lot of pressure, there is a lot of stress already on the health system. And to have palliative care as an important component, or to have a palliative care professional be placed in all of the hospitals or healthcare delivery infrastructure, so to say, is going to be difficult. And therefore we see a point of entry for civil society to come in and professionals working in this space, and therefore the Alliance is also working towards calling for a palliative care policy. We already have a palliative care program in the country, but integrating our asks around that is also a priority for the Alliance.
Thank you. So just moving a little bit away from the clinical interventions, and we heard so much about lifestyle, role of society, and possible interventions which need to happen outside the health sector. So let me begin with Prachi. What do you think there are any priorities that civil society could work on, or the governments could work closely with the civil society in terms of getting immediate outcomes, something we could achieve, let's say, in 2 years, 5 years? So would you give some idea about that?
I think in the overall UHC discussions that are ongoing, universal health coverage, and Ayushman Bharat also coming in and setting in at a good pace, we see a lot of opportunity in advancing the role of health and wellness centers. What they exactly right now are doing is a great thing. There are a lot of services being provided. NCDs as a whole are being covered. There are discussions that mental health also get covered under those health and wellness centers, and there's a professional. But the priority really for us as an alliance is going to be the whole discussion around people-centered care and how the voices of those who have lived experiences, and I'll just take this opportunity, if we reflect back, each one of us sitting in this room is a person living with an NCD, either with an NCD or a care provider to an immediate family member, a friend, anybody. So we are all by that definition, although we are professionals, but we are people living with NCD. So those voices and the whole concept around UHC being implemented with a people-centered lens is what a priority for us would look like.
Thank you very much. Would other panelists like to add on? What do you perceive are the major priorities which civil society could work on? Any comments from any of the panelists?
So I think diabetes is one field where the civil society can definitely play a role in many ways, and I think the first is they need support. The people with diabetes need support. They need a lot of psychological support because they are having a problem which they have to deal with throughout their life. At least cancer, after some time, they will either die or they will have treatment. But in diabetes, you have to live for 30, 40 years with diabetes. You need a lot of family support. You need support from the neighbors. The neighbors shouldn't say, oh, you started insulin or you've reached the end of your life. So we should not allow the neighbors to give their opinion. So civil society's role in diabetes is very much true, especially in a country like India. And people with diabetes need a lot of support from the civil society.
Any comments, Dr. Jerard?
I would say that I would agree with Dr. Vijay Viswanathan, sir. Hypertension and diabetes, both the patients, they need lifelong treatment, and the important part is how we empower the patients. So the other concept which is now coming up, the patient support group, I think it is one area where the community-based organizations or civil societies can have very close link with the patient community and focus, because community-based organizations can take up focus areas alone. If they take up certain focus areas for NCD, then we can work together and they will also find certain outcomes which are measurable. The other important area they can work is in the palliative care, of course. Tamil Nadu government has already taken an initiative palliative care program, a different model, more of a government strengthened mechanism. But then that is one area also where you need this hospice. Hospice care is a very important thing in palliation, which is also abandoned, and many people are abandoned and orphaned when they get into severe forms of illness needing palliation. So that is one area they can focus. Same way in the elderly care also, they come forward a lot, the civil societies. That is one area. So I think some of these areas where the patient status is very vulnerable due to NCDs is one important area. The other one is patient support group. There's kind of forming them or supporting patients and empowering and creating awareness and all those kind of things. When we do for the community, I think they will contribute a lot.
Thank you, sir. Dr. Shankar, you want to comment? In context of cancer, you think what could civil society contribute?
I think the civil society has a major role in creating awareness and in patient navigation, and particularly in palliative care, conceptualizing and promoting home care. Because home care is the ultimate solution finally for the advanced cancer patients where they are in the family environment, and the navigation will help in sort of getting morphine refills and then supportive care for other symptomatic illness. And in fact, I'm quite impressed by what Tata Trusts have done in major institutions in patient navigation. This is one area where we are lagging very much behind. So civil societies can support that area. The third area is in dormitories. Most of the abandonment of cancer treatment happens because the treatment facilities are far away from the homes of people, and they are not able to come, stay, and complete treatments, and the hospitals won't be able to take them for inpatient care. And the dropouts in radiotherapy are mainly due to this particular factor. So dormitories have been very, very useful, in ensuring the patient compliance for completing treatment. So this is another area, popularizing dormitories and then facilitating dormitories I think that's a major role for NGOs.
Thank you very much, sir. Now, I think I'm going to move to a little bit controversial question, which is about involving non-physician health workers. So we all have been talking a lot about challenges in managing NCDs. Tamil Nadu government was able to hire NCD nurses, 1 nurse per PHC and 2 nurses per government hospital. And I'm not sure how many states are willing to do that. And since I work as part of the India Hypertension Control Initiative, and if you ask me to say 2 big challenges on, in terms of scaling NCD strategies, one is human resources and second is drugs. So we do have lack of human resources even in the programs which are fairly well established. Given that context, we cannot depend completely on doctors. We can to an extent involve more nurses, but then again, there are not enough nurses in most of Indian states. So in this context, now the government of India has a policy around health wellness centers, and we are trying to involve A&M, ASHAs. So to what extent we can involve them? There are do's and don'ts, what they should do or should not do. So I would like, what does this panel think about, considering that, right, let's focus on 3 areas, which is hypertension, diabetes, and cancers. So Dr. Vijay, would you like to comment on that?
As you rightly said, we doctors cannot look after our people with diabetes. We definitely need the help of non-physicians to help us. In the rural areas especially, we need a lot of help from them, because the people in the rural areas, the ones who are getting maximum problems, complications. So I think the non-physician people can help in simple foot examination. If there is a person getting a nail infection or an injury, the wound care is so bad in India, and they can help us to do dressings for people. They can help us to do urine testing. They can help us to do blood pressure testing. So I think the non-physicians have a fantastic role to play in India as far as diabetes and hypertension is concerned. And we have studies from Dr. Mani's studies which have shown that you can train 10th standard plus 2 students.
So you think specialists and doctors will be okay with more and more engagement of non-physician health?
We are absolutely fine, because we don't want to see patients coming with complications.
Okay, that's great. So I just want to specifically touch on one aspect of that. So see, the health wellness center, or we say the role of A&M ASHA, it's more, we say they could help in screening, counseling, follow-up, all of that. But you know, the biggest challenge is actually follow-up in terms of scaling up drugs or modifying dose. So many countries allow a non-physician health worker to, as per the protocol, give a new drug, add a new drug, or modify the dose of a drug. But this seems like a challenging area in India. Would you like to comment on that, Dr. Jerard?
I want to just share one point. Before this NCD program came in all the states in this country, we all will agree that we kept hypertension and diabetes as something which will be treated by a specialist. When we all did medicine, we used to send them to hypertension clinic or a diabetes clinic, which was usually run by the general medicine people. So that was the concept. What happened with the introduction of the program across the country? You introduce the concept that a PHC medical officer can with the help of screening by a staff nurse, can judge, diagnose, put on treatment, and follow up. So that was a breakthrough. The other breakthrough which we should learn from our own program is, we have introduced this population-based NCD screening program. In Tamil Nadu model, I would like to share for the benefit of those who have come from other states. We are using the self-help group women network, whom we are training, and they are given a kit with electronic BP apparatus and the glucometer. They are able to go to houses, do a preliminary screening, suspect individuals with certain cutoff values, and refer them to PHC. So this filters off a lot of people. Instead of everybody you expect to come to PHC, you at least suspect certain people and refer. Now this again is a non-professional. It's only a 12th standard qualified, married women, and from the community. This is the 3 criteria we have kept for the self-help group women network. Now when we started off, we wondered whether it will work out. It is working out. Are they able to do it? Yes, they are able to do it. Are they able to suspect? It's a big word, suspect. giving in the hands of a community worker, practically a community volunteer. We call them as Women Health Volunteer. We have named them for the program. So naturally, certain things when we do in the program, in a programmatic mode, we can address such gaps because there's a dearth of doctors and nurses. There's a dearth of health professionals. So you should really balance these elements into the program.
Thank you very much, sir. So we are just at the end of our panel discussion. I would request each of the panelists if they would like to say a few final words to the audience. We'll start with Prachi.
I'm just going to take some hints from the question that you posed recently. And I think those set of guidelines that I was mentioning that we are in discussion with the ministry also mention people living with NCDs and youth as an important workforce because we have worked with Indian Cancer Society and from the experiences from the diseases, specifically cancer and some mental health issues, we see that people who have lived experiences, who have been through those conditions, it is essentially important that they are, and there have been instances in Delhi, for example, Ram Manohar Lohia Hospital, there is a setup where these champions or people who have survived cancer are working closely with the health professionals and providing management advices. They are providing whatever extra information and for that matter support that a person would need. So their role, and for example in mental health also, it doesn't, for conditions like dementia and Alzheimer's, it doesn't really end with diagnosis and treatment at the hospital level. It is much more than for the family and for the person when the person returns home. And things like sundowner effect, mornings and evenings. There again the role of people who have been through these conditions comes in place in counseling, in providing services, in helping them better again manage the diseases. So therefore our only urge is that people with lived experiences as well as young people are identified as a strong workforce to manage NCDs.
Thank you. Dr. Shankar, would you like to give final words?
See, at the moment, cancer control is part of the NPC DCS program. It has a certain advantage, particularly for addressing primary prevention, risk factors, and all those issues. But on the other hand, as I said, cancer is a complicated disease and its care requires much more wider investment. So there is a need to revoke or to reintroduce cancer control programs as a policy in countries. Actually, this is now happening. I think we need to pace it up. So there is a need for 5-year action plans or 10-year action plans to supplement whatever is being done in the NPC DCS to advance cancer control in a given country, and this is particularly important for India. And in the case of India, it has to be state cancer control plans because India is a huge country. And just like yesterday, it came out very clearly you cannot expect federal government to support everything. And in fact, the main role of the federal government is in relation to foreign service, defense, finance, and things like that. Health is a state topic. Unless the states introduce, the states invest, things won't develop.
Thank you so much, sir. You ended on a very nice note. So Dr. Jerard can take on from there how state can be a leader. Any final words?
The one opinion I would like to give is continuum of care and follow. That is the biggest challenge for non-communicable diseases. So the entire focus of governments should be on the continuum of care, and by screening and giving up, or by screening and not following somebody is as good as not screening at all. So if we start with screening, it has to go to the outcome, the end point. To reach that, the continuum of care and that seamless integration, how we do, this is the very important focus at any point of time for any place in our country.
Thank you, sir. Dr. Vijay?
Prabhdeep, I'll end up with 3 words.
Sure.
So first word is diagnose. Diagnose all the people sitting there in the community who already have diabetes and not diagnosed. Second word, assist. Assist the people with diabetes to prevent complications from becoming blind, kidney failure, amputation, heart attack, whatever, or stroke. Third, prevent. So prevent diabetes in people who are having high risk. So my 3 words for conclusion is help to the health workers is help us to diagnose, assist, and prevent. 3 words.
Thank you very much. That was a beautiful summary. Just for me to sum up, I think we had a very excellent discussion. Just to summarize, just for the audience. So for cancer, we agreed that the scalable strategies are testing for cervical cancer using HPV technology, HPV vaccine, breast awareness, and oral cancer screening, and overall improving the infrastructure for cancer care, and not forgetting palliative care as an important component. In terms of diabetes and hypertension, I think we need to, all the panelists agree that we can ensure that there are adequate availability of simple drugs, as Dr. Vijay said. Similarly, for hypertension as well, using simple protocols, ensuring adequate availability of drugs, community-based care, as Prachi pointed out. We cannot just depend on hospital-based care, but community-based care, broadly engaging the peers and different members of the community. It could be youth, it could be various other NGOs, civil society groups, so that it's not seen as a hospital-based activity. The NCD care should be seen as a broader community-based activity, and engaging the non-physician health worker who are inadequately engaged, because NCDs were primarily treated in the secondary care hospitals and tertiary care hospital. We really need to go down the ladder and engage more non-physician health workers to ensure that all those things which were mentioned earlier, follow-up, peer support, and those kind of things can be provided closer to the patient. And lastly, but I think the most important thing which came out in the discussion is being patient-centric. Are we really patient-centric? That is a question we should ask while designing our NCD programs, and try to see how we can provide maximum support and make it easier for the patient to seek care or to prevent disease for that matter. So policies which will help people to be more conscious about their health, giving access for places to walk. Alcohol control, sir talked about, can we put policies in place for better alcohol control, tobacco control? So because NCD is not always a matter of individual choice, it's also the environment. And now it has been shown that the structural interventions work way better than individual level intervention. So it's a combination of all these policy interventions and health system investment, which will hopefully make us move forward in the NCD control. Thank you very much, all the panelists, for excellent discussion. And I think now we'll close this session.